Hello and welcome to this video. In this video, I will attempt to cover the conduction disorders known as atrial fibrillation, which is AF, and AFL, which is atrial flutter. As usual, don't forget to like and subscribe to the channel for more content. So let's start with AF, which is atrial fibrillation. So we leave the illustration for the heart. Let's move to the left as usual and just say atrial fibrillation. So AF means basically irregular heartbeats. Irregular and fast plus fast heartbeat. Okay. A normal heart rate, as you may probably know, is about 60 to 100 BPM. However, with AF, your heart rate or the heart rate is somewhere around, I would say, normal find is anything above 100. But normally, from the patient I have seen, is about 150 BPM. So let's go back to the illustration of the heart. So if we divide it maybe into chambers, maybe somewhere along this line, like an X. That's not very good, but it's fine. So somewhere around here we have the SA node. So let me just put the arrow. SA node, which is where the electrical activity in the heart kind of begins. And we have the AV node. Let me see if we can just put it. AV node, like that. And then, you know, electrical conductivity goes through the bundle, you know, the bundle branches here, kind of like they go like this and kind of like spread out evenly. Okay, so it kind of like goes normally that, you know, this way, something along this line. My drawing is awful, but you know, you can understand it's quite linear. It goes from the atrial. The atrial are the upper chamber. So like, let me just say, let me choose another color for this. Shall we say blue? Blue, yeah, the blue color. So these are the atrial, and these are the both of them. Okay, and we have obviously the ventricles. Okay, so if we delete these yellow lines, let's delete them out of the way. Get them out of the way. Okay, and we go back to our initial one. So with AF, so the electrical activity is a bit mostly modeled around the upper chamber. So it's like, let's say, kind of wiggling around here, then it goes to the other side, then the signal comes back, then it wiggles a little bit around here. So it's just basically a mess. Okay, and obviously this causes the blood flow to not be very good, and that is why basically when you have that is why you have AF. If you decide to do an ECG, which is electrocardiogram, so let's move to the left again, or to your right, whatever you're watching. And we have like a small illustration of an ECG. So you have like very, very non-visible P waves. Then you have the signal, and it very irregular. Then you have another one. Then there's a long space. Then you have another one. Then you have another one closer. So what I'm trying to illustrate is just irregular heartbeat. And the main thing is that you can't see the P waves very well. So let's choose like a yellow color. And P waves, yeah, not visible. Another thing that I forgot to mention previously is the reason why AF occurs. So basically, I mentioned that the signal normally goes from the SA node to the AV node down evenly through the bundle, which causes a normal flow of blood. However, with AF, for example, and this is just like an example, AV node decides to create its own signal, right? And then some other signal comes from the lower chamber, or the signal. So yeah, so it becomes very confusional, and the heart becomes quite irregular, and obviously blood is not pumped out properly. Okay, so should we just put over here we have abnormal blood flow. So let me just delete things out, so if not this becomes quite crowded. Let's get this out of the way. Okay. So with all that information, so what are the common symptoms? So let's move things around a little bit. So let's just say common symptoms: dizziness, palpitation, which basically means that the patient is more aware of their heartbeat. So we present with chest pain or angina type symptoms, and most commonly shortness of breath. On physical examination, so let's just say phys exam, you will notice the pulse is irregular, like we've mentioned before, and plus fast heart rate. And we said, anything above let's say 150 or around 150. Those are the main things you would find. But oddly enough, many patients actually are asymptomatic. So this diagnosis can be quite random, if you have to say the truth. This leads me to the next point where I want to cover, which is the treatment. Okay, so treatment can be divided into three parts. So one of them is rate control, which is basically we want to make sure the heart rate is normal. Okay, because if the symptoms if not controlled, if the heart rate is not controlled, so if not controlled heart rate, it can go up to 180. So that's quite high, that's quite dangerous for the patient. Okay, and the common treatment for rate control is using a beta blocker such as labetalol, propranolol. Let's just say propranolol, these are the most common ones, but they're different types depending on the patient. And sometimes you can also add maybe a calcium channel blocker. I don't know. Common one is verapamil. And if the rate is still quite not right, they may also add like digoxin, which is kind of like helps with the muscle contraction, and it basically interferes with the electrical impulses of the heart, allowing it to be regulated. I don't want to go too much details about this. This is what you need to know for the nationals, okay? Sometimes you need to cardiovert the patient. Obviously, you can do cardioversion, which is your classic physical way, which, yeah, you don't want to do that, but you can do that with chemical cardioversion. So let's just say cardioversion. And the classic one is amiodarone. So yeah, so it just basically you reset the heart to its normal rate. Now, once you use amiodarone, sometimes patients will have a normal heart rate, but after a year, on average, the heart rate goes back to AF. But depending on clinical details and the type of patient. And the third thing that you want to do with AF patients is, let's just say, stroke prevention. Very important, because the blood flow is not very good, they have increased risk of developing a stroke. Now, well, you wouldn't do this, but there's a tool called the CHAD2 score, basically. I'll just say CHAD2 DS2VASC toolkit or tool, which is basically it basically calculates the risk of stroke. And treatment will revolve around using basic anticoagulants. This can be anywhere from Unowax, which is like Apixaban, or Apixiban. Let me think. Apixaban, yeah, Apixaban. The common one you will see is Rivaroxaban. I'm really butchering these names. And if it's a patient like an elderly patient, they'll probably be on warfarin. And each one of them have their own risks and the pros and cons. But yeah, this is the main thing you should know about AF. Now let's scrap all this and go to atrial flutter. Oh my god, my writing is awful. Atrial flutter. So atrial flutter is very similar to AF with just slight differences. So going back to this illustration here, so let's just zoom in back to this. So normal signal should go from the SA node to down the bundle branch, and through the AV node. Okay, so it's kind of like a simple flow. But with atrial flutter, the signal or the electrical activity is much quicker in the upper chamber, which are the atrial. Okay, so high signal, high frequency. Okay, so what is going on is that the signal is passing through the atria, okay, much more quicker. And so basically, let's say in the upper chamber we have 300 beats per minute, so which is quite high. So to compensate, your AV node blocks some of the signal. Hence why in the lower chambers, which are the ventricles, you have much less BPM. So it's like 180 BPM. I think that's the maximum we can go anyway. I hope you guys could understand this. It's quite difficult to explain. Okay, so what is going? The signal is all muffled, and the atria is very complicated. The heart is really trying to compensate, and you have all the same symptoms of AF. So the symptoms are the same. So if we go back to this illustration, so the patient will present still with dizziness, still with palpitation, chest pain, and shortness of breath. Physical examination is all the same. Like before, some of them are symptomatic. Treatment revolve around rate control, cardiovascular, and stroke prevention. So what's just one final difference? So we just say, select the blue. Most findings same as AF. So the main difference is the BPM, and another thing that is quite different is the ECG or the electrocardiogram. So let's just have a simple illustration. So if we do like a flutter type ECG, so you have the QRS, flutter type data, QRS, flutter data, QRS. So what I'm trying to say that you can see that you can see the flutter, it's kind of like a flutter type wave. However, the pulse of this patient is regular. Well, the ECG is regular. Let's just delete this. Let's delete this away. So you can see regular ECG. Okay. Sometimes the heart rate is so quick, this conduction disorder is treated as an SVT. That's it, guys. I hope this video was clear enough. Obviously there was a lot going on, but I hope you guys enjoy it. If there's anything that is not too clear, don't forget to leave a comment below, like this video or dislike if you are that kind of person, and yeah, don't forget to subscribe to my channel for more content. See you guys in the next one. Goodbye.